I'd now like to welcome Jackie Bowens to introduce our keynote speaker. Jackie.
Thank you so much, Gail, and hello and good afternoon to all of our participants. I am Jackie Bowens, and I'm the President and CEO of the DC Hospital Association, and I have the distinct honor and pleasure to introduce to you our keynote speaker, Dr. Christopher King. Dr. Christopher King is an academic administrator, associate professor, and strategist who's board certified in healthcare management with expertise at the intersection of institutional racism, social determinants of health, and healthcare administration. He envisions a world in which health status cannot be predicted by race, social class, or place of residence. As chair of the Department of Health Systems Administration at Georgetown University, Dr. King provides visionary leadership of the department, which houses a BS in Healthcare Policy and Management and an MS in Health Systems Administration. As an associate professor, he teaches and creates curricula that bridge the gap between healthcare and public health. Prior to joining Georgetown University, he served as an assistant vice president of community health for MedStar Health, where he established a regional community health strategy. Prior to his work with MedStar, he served as a senior leader for Greater Baden Medical Services, Inc., a federally qualified health center located in Southern Maryland. In this capacity, he had the opportunity to manage federal grants. He oversaw support services and secured more than $7 million in public and private grants to promote health equity and improve the health of vulnerable and underserved populations. Dr. King also served as a former chairman of the Consumer Health Foundation Board of Directors, where he spearheaded regional efforts to heighten awareness of the relationship between systemic racism and population health. Dr. King's research investigations and thought leadership have been published in esteemed peer-reviewed journals. His most recent publication, Health Disparities in the Black Community: An Imperative for Racial Equality in the District of Columbia, is truly a call to action for our city. He is a commissioner for the DC Commission for Health Equity and a fellow of the American College of Healthcare Executives. Dr. King attained his PhD in Health Services Administration with a focus on vulnerable populations from the University of Maryland, College Park. I can't think of a better and more important way to celebrate Healthcare Equity Week than a deep dive into the health equity conversation. It's important to note that Dr. King also serves as a member of the board of the DC Hospital Association and has really been integral to our efforts to start and engage in this conversation regarding systemic racism and healthcare equity. I couldn't be more proud to be associated with Dr. King and welcome him in starting this conversation. Dr. King, the floor is yours.
Thank you, Jackie, and thank you to the magnificent team that has put this day together to make this happen. Let me share my screen. Okay, we should be good, right? Can you see my screen?
Yes.
All right, wonderful. So again, it is a pleasure to be here with you this afternoon. I am so thrilled about this topic. Racial equity, a prerequisite for advancing quality and population health. This, my friends, is the work that must be done. As I was prepping for this talk, I couldn't help but to reflect on the past few decades. We've made quite a bit of progress in healthcare. For example, as an industry, we have socialized terms like health disparities, social determinants of health, and health equity. We've established national class standards, the culturally and linguistically appropriate standards that have been released, and cultural competency mandatories have been integrated in routine trainings. We've instituted the electronic health record to improve quality and efficiency and safety, and I can go on and on. But despite all of these accomplishments, we continue to see these stark differences in race when it comes to both health and healthcare outcomes. And here we are, my friends, we're dealing with a pandemic that is disproportionately impacting people of color. It's 2020, and here we are witnessing senseless killings of Black and Brown brothers and sisters. And here we are with a president who has taken action to withdraw federal funding from institutions that are delivering anti-racist education. This is a moment of inflection, and as unfortunate and as dark as the world may seem right now, I do ask and question, is this the moment for seismic change? So many of us have been inspired by the diversity of youth activism, and prominent corporations such as Bank of America and Citibank are making long overdue investments in communities of color. So the question I have is the nation poised to do some heavy lifting and reckoning with its history? I certainly hope so, because we know that policies and practices got us to this point. And as a result, we know that policies and practice can get us out of this mess. But it requires intentionality. It requires all sectors of society to go through this process of introspection and detect how their institutions contribute to racial injustice. Because systemic racism, as we all know, is baked into the DNA of the systems and structures that govern our society. And the institution of healthcare is not exempt. So it's my hope that what I share with you over the next 45 minutes will be inspirational. It's my hope that this message will stimulate some curiosity. It's my hope that this message will stimulate new ways of thinking about the important work that we do each and every day. And it's my hope that this work will help you in your own journey and our journey to navigate a world that is extremely complicated. So let's get started. It's important for me to learn a little bit about the audience. So I think we have 4 questions, and I'm going to ask my colleague, Julie, if you can launch the poll. This will give me a sense of who's here. So question 1, I work for an organization that has made an explicit commitment to address racial injustice. All right, it looks like most of you, well, it looks like 67% and 26% are unsure. I think that's an important statistic to keep in mind as I go through this. So thank you for answering that question. All right, the second question. I feel comfortable talking to my coworkers about behaviors, about systems and processes in our work that may disproportionately disadvantage people of color. Yes, no, or I'm just unaware. All right, it looks like the majority of you have expressed that you are comfortable talking to coworkers and colleagues about issues that disproportionately disadvantage people of color. That's great. And then 17%, it's important to note, are not comfortable. So thank you for participating in that question. Third question. I can provide examples of how institutional racism affects the quality of services for our consumers. Yes, no, I am unaware, or I am unsure. Okay, so the majority say yes, 20% are unsure. I think that's an important finding here. Thank you, and we have one final question. It's a bit different, but it's always good to know the answer to this question. I am a native Washingtonian. Okay, so 23% of you who are on right now are native Washingtonians, and if I were voting, I would raise my hand, and then the majority are not. So that's an important piece as we think about our city, and I think we're all familiar with gentrification, how the city is changing, and the tension that we're observing between native Washingtonians and folks who are newcomers to the city. So thank you for answering that question. All right, so let's go to the next slide here. I have a few objectives for us. One is to highlight some of the noteworthy racial differences in health status in the District of Columbia. I'll take time to reflect on the evolution of healthcare and the narratives of people of color. We'll examine how healthcare is a microcosm of a broader ecosystem that's rooted in racial injustice. And then again, defending the argument for why racial equity is a prerequisite for advancing our quality work. I'll share some examples of institutional norms that perpetuate racial differences in patient experiences as well as clinical outcomes. And I'll wrap up by sharing some tools and some resources that may be helpful in your work and your personal journey as we navigate the future. A few assumptions. One, healthcare is a microcosm of a broader society that is riddled with injustice. We have to be sure that we recognize that. And there's this sense that as I've talked with folks in the industry, that they think that racial diversity is the panacea. We know that we can have racial diversity at all levels of leadership, but that is not that's progress, but there's a lot more that's involved in this work, and it's called intentionality. And all humans are susceptible to implicit bias. It shows up in our work each and every day, and we need to create systems and processes to mitigate risk associated with implicit bias. And finally, Black and Brown people have a very complicated relationship with the institution of healthcare. So I have a video just to get you thinking and stimulate some thought around how deep this is and what this actually looks like. So this is a short clip from a series of videos that were produced by Blue Cross Blue Shield. It's just like a minute and a half.
My grandmother tells a story of hospitals in her day, one of barriers, one of trauma, one of fear. When we are sick, she pulls remedies from a tattered notebook, recipes passed through generations of those misunderstood by the world around them. She ensures this cold, this ache, this fever will break by morning. All we need is this prayer, this herb, this belief that better days are coming. She doesn't speak of bad health. She says with stern eyes, only speak life. A lesson, a warning, and a hope in one. Packaged words birthed from a time when healthcare didn't look like help for us. I feel this chill down my spine when I am ill. When my only option left is a doctor's office or the never-ending maze of a hospital. The fear that there will be assumptions about who I am, that things will be ignored like culture and beliefs, that I won't be heard, that history repeats itself. Fear that these hallways will be the same broken roads instead of bridges to new understanding. I envy those who don't have to sit with crossed fingers hoping, envy their peace of mind and comfort. All anyone wants is to be understood, to be heard, to be told that help is actually on the way.
I think they did a really great job with that, and there's a lot to unpack in that 1.5 minutes. And I'll, a lot of it will resonate as we go through our time together. So the narrative is consistent with what so many have told us in the work that we do. I've been very fortunate to do assessments and engage the community to learn about their healthcare experiences. And a lot of what they tell us is reflected in that video. Here's another case I'd like to introduce, again, to stimulate some thinking. This is the case of Miss Hazel. Miss Hazel is a cancer survivor. Give me one moment. Let me pull up I want to be sure I get this right. She is a cancer survivor, and she was diagnosed with laryngeal cancer 1 year ago and she couldn't believe the diagnosis. I mean, she really thought that her providers, it was some type of conspiracy. And I remember her telling me that they could just be making this up for research purposes. And as reflected in the video that we just watched, Ms. Hazel is a spiritual woman who brings a deep and profound level of distrust when it comes to the healthcare delivery system, always questioning the motives of her provider. And when an investigator, a clinical investigator, recruited her or attempted to recruit her for a clinical trial, the answer was an unequivocal no. After a tracheostomy and insertion of a PEG tube for feeding, Ms. Hazel bravely pursued radiation and chemo, her Bible always by her side. Although she has beat cancer, she is now experiencing a radiation side effect that has complicated her recovery, prolonging her stay at a local skilled nursing facility. Ms. Hazel is in the company of approximately 1.4 million nursing home residents who simply cannot afford to get COVID. And her loved ones, they're heartbroken because she's alone. Her fate depends on the care team's passion for their work and their adherence to evidence-based practice. Her son, who's been by her side throughout this entire journey, has been her advocate. And now he cannot be in the room with her when those interactions are occurring with her providers. He can no longer pick up on the nonverbal cues that would suggest that she's having a problem because she doesn't like to complain and she doesn't want to cause trouble. Her son cannot be there to help her process medical information that can sometimes become extremely overwhelming for her. He can't be there to hold her hand and play her favorite game, hangman, with her. So I'll share with you, when she received her cancer-free diagnosis, I want you to get a sense of how hilarious and fun Ms. Hazel is. This was her happy dance, all right? One more thing I'd like to share with you. I am Ms. Hazel's son. This is my mother, and this is our story. For the past year, my mother has seen over 30 doctors. She's been in over 5 hospitals and 3 nursing homes. And I've been right beside her throughout this process. And here are a few observations. First, we've seen the best of humanity. We've seen the best of people and the power of healthcare teams and power of teamwork and compassion. We appreciate that. But on the other side, we've seen a lot of what we're here to talk about today. The majority of the ENTs that have laid hands on my mother have been white males who did not take time to learn about her 67-year-old story. Some of her providers had dismissive mannerisms, and their approach changed after I disclosed my identity. We actually had one specialist that recommended that she have a laryngectomy. And after I intervened and shared a little bit about who I am, the provider was open to more exploratory options. People of color were significantly underrepresented on the boards of the 5 hospitals in which she received care. The reading materials, the images, and the artwork did not reflect her cultural identity, and discharge materials were not culturally nuanced, nor were they simplified. There's so much that I can share with you about my mother's story, but I just don't have the time right now. But I can tell you that, I do this work in the textbook version, right? And to actually see it happen and play out in real life with the person that I love the dearest, my mother, to see how institutional racism is baked into the DNA of our healthcare delivery system has never been more apparent to me. Addressing this problem requires us to reflect on the evolution of medicine in this country, and more specifically, the narratives of Black and Brown people. I argue that it's high time that racial equity concepts are normalized as we think about quality and safety. And that's why I'm so thrilled to be here with you at this moment. On the right-hand side, the right photo, you can see a picture that was taken recently. There's a lot going on in this photo. You see masks, you see a barrier. We can't get close. I haven't been able to hug my mother since March. And there's so many families that are dealing with this. And I just ask you to keep my mother and the 1.4 million individuals who are in nursing homes in your prayers. So we can't deliver high quality healthcare without a new and improved system, one that takes into account the social and environmental conditions that influence health. As an industry, as I said earlier, we've made some progress, but we are still operating in a medically centric system of care. We have not cracked the code on the delivery of healthcare. And as we work toward this vision, proactive steps to dismantle systemic racism within our institutions and beyond will be a prerequisite. Let's talk about why. I think all of us come to work each and every day with the intent to do the right thing. But the challenge is the systems that govern our society, the economic system, the education system, criminal justice, and yes, the healthcare system. All of these systems are infused with and impacted by the racism in which they were created and maintained. And here's a visual for you. The healthcare delivery system is a microcosm of a broader ecosystem that's riddled with injustice. We see the ramifications through racial trends that we observe when it comes to who has public insurance, who's more likely to have a preventable hospitalization, who's more likely to have a late stage cancer diagnosis. So when we have deficiencies in the broader ecosystem, we are faced to deal with it within the walls of our institution. But again, we have also been part of the problem. I share this slide with you for context. If we use 1619 as a starting point, policies and practices that legalized slavery and segregation were intact for approximately 83% of the time. It's going to take a long time to undo this damage. And I would argue that we are not even in the green space. You see that green zone on the right-hand side? I think it should probably be maybe a greenish yellow zone, or maybe we should create a new color for it. Think about voter suppression. Think about mass incarceration, police brutality, and a significant wealth gap. I argue that we are still not in the green zone because of inequitable conditions, leaving us with neighborhoods and communities that do not have equal access to opportunity across the lifespan. And no matter where we go in the world, when one population has more access than another, health disparities will emerge. In the United States, these disparities are a significant contributor to the more than $6 trillion that we spend on healthcare annually, 2 times more than other industrialized countries per capita. As you can see here, we are literally off the charts. Something is wrong with the system. So how does this play out in our city? For perspective, I'm sharing a few findings from a report that we released just a few months ago. The report serves as an imperative for racial equity in our city, the District of Columbia. Clearly, we are a racially segregated city. And we know that the more segregated a city is, the more pronounced the disparities will be. In fact, on the scale of 0 to 100, where 0 represents a community or a city that is completely integrated, and 100 represents a community that is completely integrated, we are at a 68. And when compared with white residents, the hypertension rate in Blacks is 4 times higher. Death rates due to coronary heart disease, 2.5 times higher. Death rates due to stroke, 2 times higher. Death rates due to diabetes, 6 times higher. And you can pick and choose the cancer and observe the disparity. Note that the death rate due to prostate cancer is 4 times higher, colon cancer 3 times higher. Again, the reference group is white residents. We also looked at wards and noticed significant trends between the most significant differences between wards 8 and ward 3. As you can see here, the infant mortality death rate is 6 times higher in ward 8 when compared to ward 3. And the median household income for ward 8 is the median household income for ward 3 is almost 4 times higher than ward 8. We looked at preventable hospital stays and patients with Medicare. The rates in Blacks with a preventable hospital stay, 2 times higher than their white counterparts with Medicare. So what does this all mean for hospitals and their partners, right? First, as I said earlier, we have to recognize that the institution of healthcare, has been part of the problem. And just like other sectors that are examining how institutional racism plays out in their work, it is incumbent upon us to do the same, because the evidence is clear. The sources I've used to support this talk are listed here. These are some of the most frequently cited robust peer-reviewed investigations on this topic. When we control for factors such as income, when we control for insurance, education, employment, there are racial differences in patient experiences and patient outcomes. And most notably, we see this in cancer treatment. We see it in specialty care referrals, pain management, lower limb amputation, and communication styles. And I'd be remiss not to mention and remind us that equity is one of the IOM quality domains. Equitable care is defined as providing care that does not vary because of a personal characteristic such as race. This approach, my friends, takes us closer to our vision of racial equity in health, which is achieved when race is no longer a predictor of a health outcome. And if we apply a racial equity lens in quality and safety, it means we are applying measurement skills to unearth the policies. We're applying measurement skills to unearth the practices and the incentives that disproportionately burden people of color. And we use the lessons that we learn to dismantle those norms. We use the lessons that we learn to inspire creativity and test innovation. And a reminder that race is a social construct. I tell you, this gets me all the time. I get fired up every time I talk about it. The fact that we are working in an industry, healthcare, that still has not perceived race as a social construct is an inherent flaw. It's 2020, and there's this tendency to pathologize race and develop algorithms and protocols solely based on a patient's race. I would argue that this is a half-baked approach. It's a half-baked approach that undermines how social and environmental conditions shape health. It's a half-baked approach that undermines how systemic racism is a root cause of racial differences in health status and health outcomes, not biological differences. And if we need an example, let's take a look at COVID. COVID-19 hospitalizations, COVID-19 mortality trends. In the District of Columbia, Blacks represent 3 out of 4 deaths caused by COVID. This study, which was published just a couple of years ago, actually it was 2016, by a researcher, Hoffman and her colleagues out of Princeton, they uncovered a host of medical fallacies in med-stu perceptions. The most common was that Black skin is thicker than white skin. The second most common fallacy was that Black skin coagulates more quickly than white skin. There are 9 other fallacies that were documented in this study by med students. These perceptions reinforce that you don't eradicate a system built on racialized medical fallacies overnight. Go back to the graphic, the 400-year graphic that I just shared with you. It's going to take some time to get all of this craziness out of our system. So now I'd like to share a few examples of how we apply racial equity concepts in health and social service operations. This is a framework that is evolving in my head. You know, I've been very fortunate and blessed to do this important work and putting together, you know, some thinking around what does it take to create racially equitable systems of care. And so you'll see here that the bubbles represent domains, and we start with collecting and analyzing the right kinds of data. Again, making sure that we are intentional about workforce diversity and inclusion, and looking at our environment, making sure that it is reflective of the culture and the communities that we're serving, and that we recognize implicit bias is real and it is a contributor to medical errors and differences in how patients are treated. And the importance for us to build systems that have the capacity to meet the needs for patients in real time. And we can't do that without strategic partnerships. And then advocating for systemic change. How can we use our voice both individually and as institutions to advocate for systemic change? Again, within our institutions as well as in the broader ecosystem. All of these domains must be applied using a socio-ecological historic lens. And I'm going to go through just a few examples of what this would look like. You're probably familiar with real data collection, right? That's collecting data on race, ethnicity, and language. And yes, it's extremely important that we are accurate in how we're collecting real data. It's not easy. It sounds simple, but it's not. So I've included a link on best practices. Again, I think you'll have access to these slides. There's lots of hyperlinks embedded in the slide deck, by the way. So you would just hover over it and it'll take you directly to the source. In addition to real data collection, we should build this capacity to do spatial geocoding that allows us to look at morbidity, mortality, and utilization trends at the neighborhood level. And when we overlay the racial, ethnic, and language findings with neighborhood findings, the stage is set for much more precise interventions. I do want to share a lesson that DC residents have shared with us in our work in community health. When it comes to answering questions about race, ethnicity, when it comes to answering questions about housing and income and all those things, there's a lot of resistance to those questions. And how can we be more effective in getting the right responses and increasing our response rate? We have to do a better job explaining why we're asking these questions. The community has made that very loud and clear. Tell us why you're asking us questions that we don't associate with medical care, right? And so, or we have a negative perception about it, right? And so it's important that we are proactive and have a system in place so that people are comfortable asking those questions. So for any organization that's collecting these types of data, I strongly recommend perhaps proactive developing scripts for staff. For example, Mrs. Jones, we collect this information because we want to be sure that all of the diverse communities that we serve are getting the best care that they need. I shared earlier my mother's story, and I mentioned how the environment of care did not reflect her identity. You also observed this in the Blue Cross Blue Shield video that you saw earlier. So some organizations such as Brigham and Women's Hospital, they're addressing this. This is a picture of department chair portraits that have historically been on the walls at the hospitals, in the hospital's amphitheater. And in an effort, again, an intentional effort to create a much more inclusive feel, they've removed the portraits. So my question for you is, what does your environment of care look like? You know, I recall when I worked for Greater Baden Medical Services and FQHC in Southern Maryland, we opened a WIC clinic, and we had all of these marketing firms trying to sell us materials for to put on the walls, and to make it to beautify the center. And we just said nope. We're doing this ourselves, and we're going to work with the community. And we engaged schools and local artists, and we created an environment that reflected that community. That's the work that we need to do in healthcare. Another intervention is learning journeys, or getting out of the clinic environment and literally going into the communities that we serve and learning about the day-to-day challenges that people encounter. This is an example of how we can engender compassion and cultural humility and evolve from medical care to healthcare. I heard Jackie mention earlier, she had mentioned that I was on the Consumer Health Foundation, a local foundation, on the board of directors. I was the chair. And during that time, we, and the foundation continues to do learning journeys. We would visit some of the most disenfranchised neighborhoods in our region and sit on people's sofas and listen to their stories. And what we learned translated into a different level of how we talk about our work at a board level. And it resulted in a change in how we did our grant making. We took a bold approach and explicitly named racism as a root cause for both health disparities and income disparities and so many others in the Washington National Capital Region. So what you see on the right-hand side, this is a picture of Shanika James, a former New Jersey resident, a former resident of a New Jersey apartment complex. And this made headlines. The management company, as you can see, neglected their responsibility in keeping the units here up to code. As you see, these are deplorable conditions, very hazardous to health. And if I were Shanika's medical provider, it'd be in my best interest to help Shanika address this. This is another example of how we evolve from medical care to health care. And some institutions have medical legal partnerships, like we have a medical legal partnership out of Georgetown that's doing good work, helping folks like Shanika. They're partnering with medical providers to be sure that issues like this are addressed. Again, this is healthcare. Implicit biases are the unconscious decisions that we make based on what the world has presented to us, a very unjust world. It happens fast and we have no idea that we're doing it. And in most cases, implicit bias, guess what? It works in our favor. But sometimes it leads to decisions and perceptions that are public, that are against our what we believe about ourselves, right? And we know these biases are more likely to show up when we're multitasking, when we're under stress, or when we have a need for closure. We're in healthcare, so this is way too familiar to us. And because of the nature of the work that we do each and every day, we are especially susceptible to applying our own biases and applying our biases on consumers, patients, and colleagues. And mindfulness is one way that we can do better, right? It's being present in the moment and freeing ourselves from the distraction. It's one of the best ways to minimize harmful decision-making. Of course, this takes practice, and some organizations are building cultures around mindfulness as a means of mitigating risk. If you're interested, you may want to take a look at the Institute for Healthcare Improvement. They have a training module on incorporating mindfulness into clinical practice. And this falls into the sphere of work that they're doing around joy at work. In 2014, the Institute of Medicine, at that time it was the Institute of Medicine, formed a committee to identify the social and behavioral domains that could advance meaningful use in the electronic health record. And while there's been quite a bit of progress in this space, both locally and nationally, more work is needed around EHR interoperability and integration across providers. And when I say across providers, I'm also talking about social service providers. I know we have, I think I saw that Food and Friends, Carrie has presented here today, or will be. How do we make sure that there's funding mechanisms to support the work that community-based organizations are doing to advance our population health goals? So more funding mechanisms are needed to make this happen. And as we think about advocacy, there are lots of collaboratives that have convened and continue to do great work, investing in historically marginalized communities of color. You may want to take a look at the Healthcare Anchor Network. It's a collaborative of over 50 hospitals and health systems that are working with community-based organizations to improve the social and the economic conditions of some of the most impoverished neighborhoods in their service areas. Through this work, many of these entities have already seen reductions in readmissions, as well as improved utilization of primary care services. A few years ago, my colleague had mentioned the Consumer Health Foundation, Unique Redwood, who's the current president and CEO of that foundation. We had this work published in the Journal of the National Medical Association, titled The Healthcare Institution, Population Health, and Black Lives. And it was the first peer-reviewed publication that lays out a framework that contextualized the Black Lives Matter movement with the triple aim. How do we improve the patient experience, decrease medical costs, and reduce or eliminate racial disparities within healthcare settings? The framework includes interventions and outcomes, many of which I have covered today. So this may be a resource for you as you think through the work that you're doing in the community. And as we recognize different institutions, they're on different places on this racial equity continuum. Some are in denial and think that we don't have an issue with race. Some are struggling with, yes, we have an issue, but we don't know what to do about it. And so they're grappling with what do I do, right? And then we have some institutions that are trailblazers and really doing some interesting work in this realm. Regardless of where your organization is, if you're seeking a tool to assess readiness, this may be helpful for you, particularly around stimulating conversations and thinking through accountability metrics. So again, you would just click on this and it'll take you directly to the tool. By the way, in preparation for this talk, because I figured someone would ask the question, which makes a lot of sense to ask the question, what about HCAHPS? And are we seeing any trends by race, ethnicity when it comes to HCAHPS scores? So I did do a bit of a lit review, and what I've learned is that there's mixed findings. So there's no consensus. There's some studies that show that there's no difference, and some show that there is a difference. But one thing that we know for sure, people of color are more likely to receive care, and this is national, all right? People of color are more likely to receive care at hospitals with lower ratings based on the 5-star CMS quality rating methodology. And here's some work that my colleagues and I literally just had published. We looked at over 3,000 hospitals of all types and found that those with lower quality ratings were more likely to be housed in low-income communities of color. And our findings support a growing argument for CMS to revisit its 5-star calculation methodology to account for factors such as patient population acuity, to account for payer mix, to account for other community dynamics that impact those metrics that they use to determine those ratings. So as I wrap up, I emphasize that we are all in this together, and we should not assume that diversity in leadership is the panacea. Take our city, the District of Columbia, as an example. Despite a history of Black leaders who have and continue to occupy the highest political positions in our local government, we still have stark and unacceptable racial differences in health, racial differences in income, racial differences in education, not to mention the impact of gentrification and how it impacts people's mental health. So the forces are much stronger than people who occupy positions at the highest level. This is a reminder that this work is deep and it requires intentionality, it requires reflection, cultural humility, and the one that I think most grapple with and struggle, and what's the most difficult from my viewpoint, is the necessity for a shift in power. Moreover, this work must be integrated as a component of a long-term strategy within our institutions, as well as the broader ecosystem. In closing, from my vantage point, a trifecta of events have sparked national dialogue and a national cue to action to dismantle all forms of systemic racism. The fact that we are not living in a post-racial era has been amplified by the senseless killings of George Floyd, Breonna Taylor, and Ahmaud Arbery. And I should note there's so many others that we will never know their names. The second, COVID-19, it has illuminated structural racism as a public health issue. And third, we have a presidential administration that this administration has removed the scab and exposed the reverberating pulse of racism in this country. So we're on this journey together, my friends, and it's our moment, right? It's our moment to push the envelope and go out of our comfort zone and operationalize racial equity concepts in our work as a means of improving quality, as a means of eradicating racial differences in health outcomes and health care outcomes. And with that, I am completely done, and I just want to thank you, and I hope that this has been helpful for you.
Thank you so much, Dr. King, for so many things. When we did our earlier webinar this spring, one of the follow-up questions that members asked when they expressed interest in getting more information on this was, now I am aware of my implicit bias and potential structural issues and other issues to address, and I need some actionable ideas about how to address them, and you included those here. several of them. So at a minimum, I will thank you for that, as I believe several of the folks who may be attending both that webinar and this one were interested in hearing that. We do actually have several questions that came in while you were talking, so we'll do our best to get through as many of them as we can, and then we will have the chat feature available, and we can pass additional questions on to you and find a way to get them to the audience members. I think the first one is a more simple one. As we post the recording, is there any issue with us potentially posting that report that you mentioned that you and your team produced? It sounds like folks are interested in seeing that.
Absolutely, that's a public report, and please, I encourage you to take a look at it.
Great.
And I should also note that it's not just a report that calls out, empirically the disparities in health and social economic factors. We wrap up with recommendations, and there's a host of recommendations for the healthcare sector and a host of recommendations for the broader ecosystem.
Sounds good. Let me jump into a couple of the questions that are a little more serious in nature and thought-provoking. I'll just read this one because I think it's decently worded. You spoke about the images and artwork in the patient education and discharge paperwork shared with your mother. Can you speak to the same phenomena in the textbooks and materials used to educate providers? Is there the same concern? Do you have thoughts on the impact and ideas on how to address that in our physician and clinician education?
Absolutely, yes, you're absolutely right. We look at the textbooks. I mean, a lot of what I talked about when it comes to those med students, remember that slide, that study that I shared with you? It comes from the language and the text, the images that you see in these textbooks and the way that people are portrayed and the case studies that are designed. And so what needs to happen, and this is great work that we're doing at the med school, we're actually looking at curriculum and identifying, and guess who's helping us tease it out? Students, right? They're helping us call it out and challenging faculty because we're really, really on top of this, making sure that we are undoing. So that is a part of the problem, and thank you for asking that question. Yes, textbooks need to be vetted with a racial equity lens.
Thanks for that. Here's another one that changes it a little bit. I think you addressed it to some degree in your talk, saying it wasn't a panacea, so I'm giving you a hint at what the question's about. Can you speak about the role of having people of color as hospital leaders, considering the importance of having providers be reflective of their patient population? How can white leaders advocate for this in healthcare institutions that lack racial diversity in leadership roles?
So I'll take the last part of that question first. And this is my point of view. Others may have different perspectives, but I try and identify white males in power who get it. And those are the individuals, those are the folks that really need to be part of this and pushing and educating and inspiring their counterparts. I can't tell you how many times I've delivered a presentation and a white male has said the same thing and it was received different by the audience, right? And so it's so important that we have white males who are, who are champions for this work, and we're supporting them and helping their colleagues understand and make these connections. The other question that you ask is around diversity, right? And yes, it's important that we have diversity and inclusion. That's an important part of this work, but just to have a diverse leadership team and just to think everything will organically fall in place and the world will be better is flawed. We have to be intentional, again, recognizing that our institution may have this diverse leadership, right? But what's happening in society that is impacting how we do our work? And so that's where the intentional piece comes from. So we have to have metrics, and we have to hold ourselves accountable, and we have to challenge our stakeholders and ensure that they are also applying anti-racist concepts and how they do their work and how they work with us.
Makes sense, thanks. You mentioned racial differences in disease prevalence and incidence. What other outcomes do you recommend measuring to get at factors that lead to those diseases? For example, measuring infant gestational age versus mortality, for example.
I think, okay, so when it comes to measurement, I think infant mortality is, you know, there's a lot that we can infer just based on a community's infant mortality rate. And so that's important. The other piece that we need to measure is early childhood education. These are counterintuitive. I remember being on a panel and someone said, oh, if there was a magic wand to improve people's health outcomes, what would you say? And some folks said on the panel, we need more doctors, we need better quality health care. And I was the outlier. I said, if we want to improve the health of the nation, we have to invest in early childhood education. And we have to look at the factors that contribute to infant mortality. When we do that, it opens the door to a lot of the problems that are inherent in our community and gives us clues for what needs to be fixed.
Well, and it's interesting you answer it that way, because that gets a little bit at this concept that how can you say you have quality care if you still have inequity? And those are the kinds of things that somebody who's trying to figure out how to deliver better quality care would be thinking about.
Right, absolutely, absolutely.
Yeah. We had a couple of questions that came in. I'm actually going to skip a few, not to slight the questions, but a couple of questions that came in as you were answering. So I think from a flow perspective, they might actually fit before we switch topics to some degree. And I'm going to read two because they're sort of similar. Very inspirational presentation. Can you elaborate on the point you made about shifting power? And a related question was, if hospitals are overwhelmingly led by whites while the majority of healthcare workers might be minorities, what can be done to rectify this situation or realize that shift in organizational power? I read those two as somewhat related, and asking you to elaborate on that perhaps a little bit.
Love the question about power. I have a perfect example. When I was doing community health work and developing community-based programs for a healthcare organization that I worked with, there was a learning curve that needed to occur because the mindset has been, we can go and save this community. And here I am raising my hands. No, that's not how we do this. You know, we're not the savior, right? The community needs to find its way. And we need to be there to maybe facilitate and provide some resources to support how the community can find its way. So that's an example of shifting the power. It's using resources that we have and providing that to the community in a way that facilitates change so that the community owns the work that needs to be done and has some control over its future, not us going in and saving the day. So that's an example of the shift in power. It's really just saying, hey, we don't know everything, and we have to just sit down and listen and learn from the people that we're serving and empower to the best of our ability the community to find its way. And what was the second question?
They were both related. The second one was getting a little bit more at how do we approach this? What might we do? So I think you actually answered both.
Okay.
Yeah, and I think we have time for one more. So I'm gonna dare to bring it up, and it's just a slight change from that last concept. Thank you for raising the issue around race versus biological risk factors. I heard it expressed once over a year ago and have not heard it mentioned again. What might be the most important step for us to take to move the needle on this concept?
Yeah, that's a really, really good question. As I said earlier, it starts with training. And so I would encourage all health profession training curricula be vetted via a racial equity lens. So let's say you're not in the training space and you're already out in the world doing wonderful work. It's up to us to call this out when we see it. So I would just encourage people to speak up when we make this flaw, again, which is very, very inherent in the work that we do. I think that the solution requires us to understand our history and why race is something that we're always checking, and we're required. Why is that in the first place? I think when people are more aware, and when we start to recognize that a person's health is mostly shaped by their environment and not biology, right? We'll think differently, and we'll have different questions, and we will do better in our work. But speaking up and calling it out, I think, is key, and recognizing the complexity of our identity, and all of these factors around us that shape who we are.
Thank you, Chris. Thank you so much. I think we do have a couple of additional questions that we can address separately. There's sort of follow-on questions or similar to ones that were already asked. And there's some questions in the chat that, as you sign off and have a chance to take a peek at, perhaps we can make sure that either you get a chance to answer or we pass them to you. I want to personally thank you so much for continuing this conversation with us and our members. As I mentioned, it was an area where we heard a lot of feedback from people that they were really looking for continuing the conversation. Ms. Bowens, did you have any follow-on comments?
Yes, again, I just want to once again thank you, Chris, for your leadership, your engagement, and your accessibility. We've been benefited by your leadership and helping us to not only start this conversation, but to make sure that, I like to say that this is not just a moment, that we really do see this as a movement and true call to action. Our hospitals are doing great things, but I think we all agree that there's some opportunities for improvement, and that our community is truly depending on us. And I'm grateful and thankful that you are part of this team and helping us along the way, but also making it safe. Making it safe for us to have these conversations, to acknowledge that, yeah, we do have some issues here. And at the end of the day, we can never have true quality without health equity. And so thank you for your time. Thank you for the effort. I also want to again thank the participants, and also so grateful for the team. A lot of work goes into putting these things together, even virtually, all right? So while we're not all, I live for the day that we can all come back together and do great things in person, but I'm also extremely grateful for the team, the quality team at DCHA led by Gail, and certainly supported by Julie, Elizabeth, Eden, and Annette. So thank you all so much. And I think we're going to transition now. And I give that back to you, Gail, for explaining kind of the housekeeping for the next steps.
Thank you both. As Jackie mentioned, we will